Okay, Doc.
Yes.
There were.
Can we start?
Yes, we can start.
There were some questions.
Yeah, there were 3 questions. Lodina is already here, so I'll ask her a question. She said, "Sir,
Okay.
please, with the assessment using the curve 60, how do you get the total?" So, Lodina, that's
Okay. Yes. So you just add. So it's just a summation of the figures you are getting. So you just add.
okay. Lodina, you want to know how we get the individual numbers? Your question is not quite clear. If you can probably unmute yourself and then ask the question well.
Yeah. Sir, please, how do you add? I'm not really getting it.
Yeah, so what you are doing is if you have your patient, you assess the patient. So your CNS assessment to tell us if your patient is confused or not. So you can check if your patient is oriented in time, place, and person, like the usual neurological exam to check if the patient is confused or not. So if the patient is confused, then you give a value of 1. Then the next one, if the patient is not confused, then you don't give any value. So that's a 0, right? Then the next one is the urea levels. So when you do your BU and creatinine, you check if you have a value 7 or more, you give a value of 1. If it's below 7, you don't give any value. That's 0. Then your respiratory rates, you count. If you are getting a value more than 30 cycles per minute, that is 1. But less than that, you don't give any value. Then you check the BP as well. Below 90/60 is a value of 1. Above 90/60, you don't give. That one, we are using individual parameters. So even if diastolic is 60 and systolic is 80, it's still below 90/60. Then 65 years, below 65, you don't give any figure. Above, you give 1. Then you add all the figures you've gotten. So if you didn't get any figure for that is 0. Okay, so that means that this patient has pneumonia, but it's not as severe. So that's 0. If you get a value of 1, you can actually manage the patient. So if you have a patient who has pneumonia, whose only problem is that he's 66 years old, but doesn't have all the others, you can manage from home. Are we okay?
Yes,
Yes,
so
sir. Thank you.
If you have all the value above 1, meaning the patient has to be admitted.
Yes, it means the patient has some things that you need to look out for. Maybe the kidney is beginning to fail. Okay, this patient is in a very, very confused state. There's something actually happening.
Okay.
Please, what was the second question, please?
There are 2 other questions, but the people who asked the questions actually they haven't joined yet. I don't know if I should ask or we should wait for them to join before I read out, because
maybe they might not join too. So you ask.
Okay.
And then
all right. So Rabi asked, some patients with pneumonia tend to have an elevated blood pressure too, even though they are not hypertensive. What is the mechanism behind it?
Okay. All right. Okay. So that is actually not the classic thing you tend to see, that a patient with pneumonia would have raised blood pressure. Okay. But you can actually relate it to compensatory mechanisms. And remember, we talked about pulse rates going up and all that. And once your pulse rate is going up, it plays a role on your cardiac output, in that your pulse rate means cardiac output to go up. And just like the way the asthma works, that can increase your blood pressure. Okay. So it's just about compensatory mechanisms. Your body feels as if, all right, okay, I'm losing fluid, because they sweat a lot in terms of fever and all that. So some sort of compensation would be triggered, and in so doing, you can have the patient's recording increased blood pressures.
Okay. Then the third question from Ronald, he said, do you add LDH or lactate test?
All right, okay. Well, it's not a usual thing, inflammation or something Makada would want to go for. Okay. You are doing that because you want to check if the body is undergoing some form of anaerobic respiration. Okay, but it's not a usual go-to lab that we do. You can simply put your pulse oximeter on your patient's hand and check the SpO2. Once your SpO2 is persistently low, then you know that the body, in a way, is not supplying the tissues with all the oxygen needed. So definitely LDH will be produced in some places, but it's not your go-to thing that you would tend to do, that you are going to check for LDH. Fine, maybe when you do it, it gives you an indication of how bad the oxygenation is. Okay, it just gives you an idea of how bad it is, but it's not a usual thing that you want to check. But if you check, that's okay. It would give you an indication of how bad your partial pressures of oxygen is.
Okay. I think that's about the questions that were there.
Yes, please.
So with the idea that maybe when you lie on the bare floor for a very long time, you get a pneumonia. It's not true, eh?
Just like when you sleep under the fan, you get a pneumonia and all that. Well, it's just one thing we know is when the weather condition is cold, okay, some microorganisms tend to grow more in cold weather conditions. Okay, there's an organism called Legionella. Okay, and this Legionella, you usually find it, one of the classic places is air conditioning. So during microbiology, they'll tell you a microorganism or bacteria that likes growing in air conditions is, the answer is Legionella. So we know that cold weather conditions precipitate the growth of certain bacteria that would the bare floor just like that. The perception there is that it's very cold. They are getting cold air getting inside you. Okay. All they are trying to tell you is that some bacteria grows in cold weather conditions. And so that thing they say, oh, he slept under the fan, he slept on this. It's just to say that maybe you are putting yourself at risk of getting infected by this bacteria that likes cold weather conditions. You get it?
Okay, sir. But it's not medically, that's not the idea.
No. It's just about the bacteria. Really, okay. If you're trying to explain it scientifically, it's just about the fact that some bacteria that causes pneumonia likes cold places, and hence cold weather conditions can put you at risk of developing a pneumonia.
Okay, thank you.
So yeah, Rabi, they've asked your question. Your question was about the blood pressure, that some people who have pneumonia tend to have an increased blood pressure even though they are not hypertensive. And I was explaining that, yes, well, that could be a compensatory mechanism, because you remember we said that one thing we see is that your pulse rate may go up. And once your pulse goes up as a compensation, it would inadvertently lead to an increase in your blood pressure as well. Okay, because cardiac output will go up, and that's what can happen when you are having a patient with pneumonia. But most of the time, their BP is fine, and when the pneumonia is getting severe, their BP goes down.
Okay, Doc, could you also go over the LDH and then the lactate test? Ronald is also here.
Yes. So what I said was that with the LDH, it's not a classic test investigation tool that you want to do for your patient who has pneumonia. LDH, high levels of LDH means that your body is undergoing anaerobic respiration, which means that your body is not getting enough oxygen. So to make ATP, your body is making it through an anaerobic process, and that will lead to the production of LDH, okay, or lactic acid. If you are thinking, all right, okay, the pneumonia is that bad that is preventing oxygen from getting in, so let me check LDH and see how bad LDH is. You can just put a pulse oximeter on your patient, and the SpO2 there will tell you that the patient is getting a poor oxygen supply, and that should give you an indication that, all right, this patient will definitely have a system going through some sort of lactic acid production, okay? But clearly, your SpO2 will give you an idea of what you are expecting. However, if you decide to check for it, that's fine, but it's not like classic for it, okay? Should I add that some other types of pneumonia, like for example, pneumonia in the immunocompromised state? I gave an example that pneumocystis carinii, okay, LDH goes up. Something like TB, LDH can go up, okay? So it's just to give you an idea of what is happening. But if you don't do it, it won't hurt, it won't kill the patient. Are we good?
Yes. Yeah, we are good.
Yes, we are good.
All right, okay. So next weekend we'll try and complete the cardio, and then hopefully within the week of after next weekend, within the week we'll do some sessions, and then we'll do some sessions,
your
and
microphone
then
for us. We'll be grateful. Thank you. No,
yeah.
please.
So next weekend we'll complete the cardio, and then the week afterwards we'll try and have 2 lectures within the week. I think I'll have some free time, hopefully 2 lectures within the week on respiratory, and try and complete it by that weekend too, so that we can do GIT and prepare for exams. Okay.
All right.
Yeah, with the exams, would you give us the areas?
Exams, cardio, GIT, and respiratory. If there's time, we might discuss some case studies so that we have an idea of how the questions will look. I hope there will be time.
Said there will be time. We'll have that time.
Okay. Do you have any idea on when you reopen after vacation? Like how long your break is going to be?
It's going to be a month from 10th May to I think June 11th or so.
Okay.
Let me be sure. So give me a second.
Okay.
Okay. So the vacation is 10th May.
Yeah.
May 9th, yes, and then we resume second semester. June 14th.
All right. Okay.
Yes, sir.
Okay. So during that time, we can at least have a lecture or 2 in a week.
Okay.
For infectious diseases, if we are up for it on Zoom, a
Yes.
lecture or 2 in a week on infectious diseases, so that we'll be able to complete.
No problem.
Because when we get back to school, we'll have to finish everything by mid-September or early September or mid-September. Otherwise, I'll be unable to finish medicine 2 with you guys.
Yes. Yes.
Right.
All right.
I wanted to ask if there'll be anything like midterm.
Mid-sem. No, so I'll give you a case study. I'm giving marks 2 for the group discussions. So I'll give you one case study, which each group will have like a case study to discuss.
Okay.
And then you would submit that if there's time. So that's what I'm hoping, that we'll use one session to do 4 case studies, which will be presented by each group. Then we'll give marks, and then we'll prepare for 100 MCQs and 5 written questions.
Then would there be some sub questions? Written sub questions.
Yes, there'll be sub questions.
Hey.
Oh,
Repeat what you said again. No? I didn't. Some of us did not hear you.
Oh, but that's oh, your seniors haven't told you. But my exams is not difficult, even though they always say the MCQs are very hard, but it's not. It's not. So 100 MCQ questions. Oh, I'll give you easy MCQ questions.
I
Let me see.
learned with medicine, they give only MCQ.
And written. Who do written? It has to be a standard exam. When you go and do your MDC exams, your medicine is not just written or it's not just MCQ. So,
Anyway,
so that's okay. So let me see. Okay, we haven't done.
Quiet.
1 meeting.
Let me
No,
see.
please.
Let's see if I can get. All right. So MCQs. So you can have a question. A raised JVP is suggestive of A, DVT, B, left-sided heart failure, C, myocardial infarction, D, right-sided heart failure, E, none of the above. It's easy, right?
none of the above.
That
None of the
above.
It's easy. Okay, there's also another question.
One thing is that it's not that we are not reading. We are reading a lot, but
yeah. Oh, but this one, I said it in class. If you follow my lecture, I intentionally hit on some things like a raised JVP. I said it's see, a raised JVP or jugular venous pressure is suggestive of. And you guys even told me when you were presenting your heart failures and all that, and we said usually when you have so A is DVT, B is A is DVT, B is left-sided heart failure, C myocardial infarction, D right-sided heart failure, E none of the above.
B
right side failure.
Right side.
Yeah. Good. So it's right side. So it's
Right side.
easy.
So why is it the right side? Why not the left? Because
They explained it in class. There was he doing some things and made the explanations in class.
Okay, sir.
Only class.
Yes, I now get it. I get it.
So when is the left to go into the lungs,
Yes.
right?
Yeah.
But when is the right, then you are going
it
to
goes
have
to the venom.
exactly. So then that's JVP. So I just need you to remember and apply. That's all.
Wow.
Let me give you another MCQ question.
Okay.
Consolidation on a chest X-ray most likely points to A, asthma, B, COPD, C, lung cancer, D, pleural effusion, E, pneumonia.
Pneumonia.
It's cheap.
Pleural effusion.
Exactly. Oh, it's cheap. It's cheap. It's cheap, right?
It's C. Yes.
Okay, which of the
it's
following infections presents with diarrhea? A, hepatitis A, B, hepatitis B, C, hepatitis C, D, hepatitis D, E, hepatitis G. Which of the following infection? It's cocoa.
Hep A.
Hep A, you're right. Hep A will present with diarrhea. Good.
Yes.
Iron deficiency anemia. Red blood cells in iron deficiency anemia, red blood cells are A, small, B, normal, C, large, D, sickle, E, secular.
Sickle now.
In iron deficiency anemia, how do the red blood cells look?
Sickle.
No,
No, it's for sickling cell people.
no.
Good.
Say it again for us.
In iron deficiency anemia, red blood cells are small, normal, large, sickle, or secular.
They are small.
They are small.
Good. Exactly.
Small.
They are small.
This one, Lotto.
They're small.
This one, as
So that is what you call iron deficiency gives you what we call microcytic hypochromic anemia. Good. So red blood cells are small and then they are faded. Okay, last MCQ question. The severity of pneumonia is determined by all the following, except A, respiratory rates greater than 30 cycles per minute. B, serum urea greater than 7 millimoles per liter. C, systolic blood pressure greater than 140 millimeters per mercury. D, age greater than 65. E, confusion.
Systolic.
C.
Good.
blood pressure.
So you see, say you know hard.
Say use this one as your misstep, so you have scored 30.
It's good, so that we can score 30 in advance.
So you see, it's easy. Let me see. Oh,
Then
it's
give it to us.
Can we get a copy of the question?
Hey,
The ones you are
you
using.
don't like it before day. You want a copy of that question. Do you know what it can do to you?
Okay, let me give you a gist of how my case study looks like.
Okay.
Then we
Okay.
close. A 38-year-old bank manager presented at the ER with an intense, unremitting left-sided chest pain. He says the pain started about 30 minutes ago. He characterized pain as being sharp and squeezing, radiating up to the neck, jaw, and shoulder of the left arm. Patients had a milder episode of such pain about 3 months ago, with laboratory investigations revealing a raised LDL level. Okay, LDL level, not LDH. Exactly. So raised LDL level. He was started on tap atorvastatin 20 milligrams daily and tap clopidogrel 75 milligrams daily, but he was not adherent to the therapy. So when he reported, you recorded a heart rate of 120 beats per minute, respiratory rate of 24 cycles per minute. SpO2 was 82%, and the initial BP, which was 180 over 100 mm, later fell to 80 over 50 without you giving any antihypertensive therapy. So when the patient came to you, the heart rate was 120, respiratory rate was 24, SpO2 was 82. Okay, and as you were managing, the BP, which the patient came with, which was 180 over 100, fell to 80 over 50, even without you giving any antihypertensive. 1I, what is your likely diagnosis? II, list the two differential diagnoses. III, what is the primary disease responsible for the development of the above? IV, explain the increase in heart rate, respiratory rate, and then the drastic change in BP on presentation. V, list 6 investigations you perform for this patient. VI, explain the role of cardiac enzyme assay and ECG in the management of this patient. VII, how will you manage this patient?
I have been.
And you got this simple.
Oh, it's easy, right?
No,
Yes, sir.
easy.
There's nothing called easy in this question. Even here, I know a lot.
If you ask my candid opinion, it is purely experience that you can use to answer this question.
You use it to answer.
Yes, it's purely
This one,
experience. It's purely
Oh,
experience.
but if you read the slides and you are in class, you answer this question easily and you get at least 16 over 20. Trust me.
Huh?
Oh, sure.
Trust me. A 33-year-old man presents at the OPD. A 33-year-old man presents at the OPD with complaints of cough, which is productive. He also complains of breathlessness, feverishness, headaches, and a pleuritic chest pain. He is a known alcoholic with a current history of IV drug use, intravenous illicit drug use. Okay. He hasn't been to any healthcare facility in a while. Vitals recorded: temperature 39.3, respiratory rate 32, SpO2 96, BP 126/68. Pause 98. What is your likely diagnosis?
Pneumonia.
This is easy.
Say
Yeah, so if
pneumonia.
the max there is 3, but if you say pneumonia, I'll give you 1 out of 3.
Yeah.
Pneumonia, I agree, because there's breathlessness, fever, headache, and pleuritic chest pain.
And
But
then
when I was,
productive cough.
and there's productive cough, so good.
Pneumonia,
So it's pneumonia.
pneumonia, second degree to coughing.
Are you sure? Second degree. No, don't say that. Say
How can pneumonia be secondary?
But no,
Secondary.
Secondary to coughing. Sir.
no, but that's
No.
not it. The coughing is part of you diagnosing your pneumonia. So the pneumonia can be secondary to coughing. There's a part, you see, when you're answering case studies, every single sentence is important, just like the way we answered that question on the page. There's a part in the question that says that he hasn't been to any healthcare facility in a while. What does that tell you?
Community acquired.
Acquired pneumonia.
Good. So then you get all the 3 marks.
Community acquired. Wow.
To some of the key things in the case study. So the second part is, what is your differential diagnosis? List 4 risk factors for the development of the above.
Okay, sir. My problem is with
Sir,
this differential.
Asthma can be a differential.
Yes, it can. Why?
Pleural effusion can be.
Yes, it can. It can.
Okay.
Pneumothorax.
So your differential pneumothorax, I'll say no, because
There is no.
a classic pneumothorax won't give you fever, it won't give you cough, it won't give you all that. Most pneumothoraxes is not secondary to an infection. You understand?